All right, just a few reminders. Census is tomorrow. I've been talking about this for a few weeks now. So what I have verified submission of your acknowledgement forms for my lecture side. Your lab instructor is going to be doing the same for the lab course as well. I have reached out to a few of you through Blackboard messages if I'm lacking your submission, okay? Or if there was any issue with it did not come through correctly, the attachment was not there, whatever the reason is, if you've received a Blackboard message from me, please respond, okay? If not, you're good to go, okay? So for tomorrow's census, I need two things. I'm looking for a signed acknowledgement form for the lecture side, and I'm also looking for proof of participation, so therefore a signature on that roster. And like I've said before, I'm tracking remote attendance as well. So remote users, y'all are good to go. So those are the two things I need before I sign off on your, well, the fact that you're on my roster and that I've seen that you've been participating in class. So those are the two things, all right? So, and your lab instructor is doing the same thing as well. So if you've received a Blackboard message from me, please respond, okay? All right, and if I don't get a response by mid-afternoon or early evening, I'm going to bother you again because I need that acknowledgement form. That needs to be signed, all right? That's an acknowledgement that you know where the syllabus is and what the policies are and all of that. That's absolutely important, okay? Okay, the practice activity, you don't have access to the ANP2 practice activity anymore, but instead you should see the quiz opened up now, okay? So the quiz is, I think, a 40-minute quiz, one attempt. So you've got to make sure you have enough time to work through that quiz without any distractions or interruptions. Because if you walk away from your screen, there's a timer that will keep continuing to count down, and so you'll miss out on minutes. We don't want that. So just make sure that you're not going to have any distractions from kids or any other family members or pets or anything else. Just make sure that you got that time to dedicate for yourself, okay? Again, that's an optional activity. It is an extra credit activity. We talked about this. If you complete this activity, I'm going to save those points for later on in the semester, at the end of the semester, if I need it. If it helps you move up a letter grade, so if you're within 10 points shy of moving up to the next letter grade, that's when those points will be relevant, okay? If not, I won't use it. We've talked about it, and I've also have an announcement that explains what the scenarios are. So if you have any questions, we can talk about this perhaps later, okay? Let's see. In terms of the lecture content, we covered blood part 1, which was basically looking at the composition of whole blood. You should have seen some overlap in lab as well. Y'all did formed elements. We discussed the role of erythrocytes and some of those erythrocyte disorders as well, anemia, polycythemia. WBCs, I did not touch upon that because this was covered in lab. So just make sure you know what the 5 subpopulations of WBCs are and what their main functional roles are, right? That's really it. We did talk a little bit about WBC development, and then we discussed leukopenia. I'm sorry, yeah, we did leukopenia, leukemia, mononucleosis. So those were some of those WBC disorders that we covered. The last part that I want to talk about today is thrombocytes, the role of platelets, especially in the process of hemostasis and the the clotting process, right? So I'm going to cover that. And then from there, move on to our discussion of cardiac, so heart related stuff. So you're going to see a lot of overlap now. In lab, I know I taught lab for Ms. Gosnell yesterday, so we covered heart anatomy. So heart part 1 slides, like the first 20 something slides, is exactly the same thing that you all have in lab. I'll cover what's relevant here in terms of the physiology, but all the identification of different blood vessels, especially coronary vessels, yeah, we're not doing that here in lecture because that's more for your lab exam, not so much here. Here, I need to piece together the physiology. So I'm going to cover some of the basic anatomy here. If you haven't heard it yet, like as in you have lab today, you will hear it in lab. You will work with an activity. You will, Ms. Gosnell, I think, is back. So she should be covering that for you all in today's labs. And I know I did this yesterday for your Monday, Wednesday lab. So again, if there's overlap with respect to the anatomy, you're listening to it and paying attention in lab. I'm covering this more from a perspective of let's quickly review this and then let's get going with the physiology aspects. Okay. All right, let's cover this first. So there were three different types of formed elements that we talked about last class. Erythrocytes, you had your entire leukocyte populations, and then you've got the thrombocytes. So what I want to discuss now is, I guess, a little bit about the developmental pathway of thrombocytes, but then really go into the whole process of how they play a role with clotting, okay? So when you think about platelets, platelets freely circulate within the blood plasma, right? But they have to stay inactive until they are needed for the clotting process. Then we got to talk about these factors that will then trigger the activation of those platelets, okay? So for the most part, platelets are going to stay inactive because you do not want undesirable clot formation where it's not required, right? So they have to stay inactive. And then you have to activate it if it's necessary. So let me explain that. When you're thinking about a blood vessel, and we cover this in lab as well, when you're looking at the wall of the blood vessel, so there's different types of blood vessels, all right? You got the blood vessels that carry oxygen-rich blood. Systemically, we call these arteries. And then you have the blood vessels that return oxygen poor blood back to the heart, to the lungs, right? That's basically going to be your veins, all right? So systemically, that's your designation. Then you have the smallest blood vessels between those two ends, right, where exchange of nutrients and gases occurs within the tissue beds, and those are your capillaries, all right? So your capillaries are really, really thin-walled vessels where it's just one single layer to its wall, right? But I'm talking more about those larger blood vessels, your arteries and veins. When you think about a traditional kind of blood vessel, not the exchange vessels, when you're looking at the wall of this blood vessel, there should be three layers. And I have it here. I'm just going to use this schematic. So if you're looking at the blood vessel, here's the lumen right through the center. This is, of course, where blood's going to flow, right? Directly in contact with the lumen, this black layer, which is your innermost layer, is called the tunica intima. So I guess this week, yeah, probably this week, you'll start working with blood vessels as well, maybe next week, where you will look under the microscope. You'll do the histology of different blood vessels, and you will look at all three layers. You'll be able to identify all three layers. So the innermost layer, which I have here in black, is basically a single layer. This is what I call tunica intima. In ANP1, we cover tissues. So hopefully you remember one of those epithelial varieties called simple squamous epithelium. Does that ring a bell? Single layer of flattened kind of cells. You saw this in several different places, like especially lining the alveoli of the lungs, the air sacs, as well as you're going to see this as the innermost lining of any blood vessel. So when it comes to those exchange vessels like capillaries, we just have the tunica intima, just that one layer, and that's it. You don't have the additional layers. Does that make sense? So in a blood vessel, we call the simple squamous epithelium that makes up the tunica intima, we call this the endothelium. Does that make sense? It's the same thing. It's simple squamous epithelium variety. We call that layer the endothelium, right? All right, then outside of the endothelium, which you kind of see here in purple, is the middle layer, which is called the tunica media. And this is where you're going to see smooth muscle. So I need smooth muscle in arteries and veins. You're going to have more smooth muscle in arteries than you do see in veins. And of course, any muscle is important for contraction and relaxation. So this would obviously allow for the flow of blood from one point to a different point, right? So upstream to downstream. Then you have outside, the outermost layer that you see in blue, this is the tunica externa. It could also be called the tunica adventitia. Both of these, I mean, this layer is basically reinforcement. So you're going to see connective tissue, mostly like a fibrous, like a dense regular or a dense irregular connective tissue, meaning you've got a lot of collagen fibers reinforcing this blood vessel. Okay, so that's going to help to anchor the blood vessel to the surrounding matrix to keep that blood vessel open to allow for blood to flow, especially relevant in the veins that carry oxygen poor blood back to the heart. Because veins have much lower pressures within those vessels, so they can collapse, right? And we don't want that. And so, how do you keep it open? So that's why you got a lot of reinforcement with the collagen that helps to keep those veins open. You also have the same with arteries, but arteries have a much higher pressure, so their dynamics are a little different, right? So we'll get to that when we get to blood vessels, even in the physiology part with blood pressure regulation a little later on. But today, I'm talking about the three layers here because I want you to know what type of cells or what type of tissues you see here, because I'm going to show you how this is all going to be very important for platelet activation, okay? So when you have an uninjured blood vessel, obviously all three layers are intact, right? No tear, nothing, everything is perfectly fine. And so then you've got platelets that would be circulating through the plasma as it goes through these different blood vessels. If all the layers of the blood vessel wall are intact, then there are no stress signals, there's no activation signals being sent out to activate those platelets. So what keeps those platelets in an inactive state? What allows them to just keep rolling along, right? Without it kind of getting sticky and starting to kind of form a plug. But how do you prevent all of that? Very simple. So you got to know this. This innermost layer, which is the endothelium, I told you this is simple squamous epithelium, right? The endothelium releases two very, very important factors, and that's kind of highlighted here for you. Nitric oxide, you may even see the designation NO, that is nitric oxide, okay? Nitric oxide and prostacyclin. These are the two factors that are released by those endothelial cells, and that keeps those platelets inactive. Does that make sense? So if you have an uninjured blood vessel, then the endothelium releases high amounts of nitric oxide and prostacyclin, and that keeps those platelets rolling along, prevents it from becoming sticky, prevents any unnecessary aggregate formation. Does that make sense? Which means if you do have a tear in that blood vessel, this is when we have to start thinking about what are the other factors that would then play a role and how do you start activating those platelets. I'll get there. Once the platelets get activated, right, when they're required and when they get activated, this is when we covered this in ANP1, like probably the very first chapter when we discussed negative and positive feedback mechanisms. Do you remember that concept? One example of a positive feedback mechanism, which by the way was if you have a stimulus, then you keep increasing that the response is to increase that stimulus. That's a positive feedback mechanism. We gave two examples there. One is clotting, where you're activating those platelets. The other was we talked about oxytocin and labor contractions and how you have that amplified response, right? So what happens when you activate platelets? They release kind of like inflammatory chemical mediators or chemical signals. And a lot of these would be involved in that process. There's a few other things as well. Thromboxane, we'll discuss this. But there's a lot of different chemicals that are released by these platelets. And what that does is it basically helps with other platelets to get to that injured area and allows it to kind of accumulate, forming an aggregate, forming a plug. So therefore allowing for that to kind of enhance that clotting process. Okay. So we'll discuss this. Um, I'll come back to this, but I want to talk about developmental first, and then I'll come back to the whole clotting mechanism. So how do you form platelets? So just like any other formed element, like RBCs, WBCs, platelets, they all start with a common progenitor stem cell called a hematopoietic stem cell. You remember we talked about this with erythrocyte development and WBC development. Yeah, maybe not. Okay, might want to go review this. Hematopoietic stem cells or hemocytoblasts, they exist in the red bone marrow. Okay, that's where it starts. So if these stem cells receive erythropoietin as your stimulus, it will allow it to commit to becoming an RBC, correct? If it receives a different stimulus like a colony stimulating factor or one of those pro-inflammatory interleukin signals, then those stem cells are going to commit down one of those WBC pathways, right? So there are different triggers here that will prompt the release of or prompt the commitment of these stem cells into platelets. Okay, so one of them is going to be thrombopoietin, very much like erythropoietin that we talked about for RBCs. Thrombopoietin is one of those signals that will allow for commitment of stem cells to go down that platelet lineage, to commit towards becoming platelets. If you remember, we talked about hematopoietic stem cells. This kind of branches off into two big lineages. One is your myeloid stem cell lineage. The other is your lymphoid stem cell lineage. Lymphoid stem cells will only give rise to your two lymphocyte populations, B and T cells. Myeloid stem cell lineage gives rise to every other formed element. So platelets are derived from that myeloid line, right? And it becomes what we call a megakaryoblast. I'm going to go to the next slide to explain this. I'll kind of go over. It's a very simplistic process. Takes about 10 days or so for the formation of these platelets. So starting with this red bone marrow, where you have your hematopoietic stem cell, and then of course through the myeloid stem cell lineage, what happens is there's a lot of there's mitosis occurring within these cells, but there's no cytokinesis. In other words, so you have the nuclear division, right, and becomes a gigantic cell because you're not really dividing a parent cell into two daughter cells, which then becomes more daughter cells, right? So that division of cytoplasm doesn't happen. So this keeps growing and growing, right, to where you have this gigantic cell, different stages. Ultimately, stage 3, stage 4 is really your like the end of this lineage or this developmental pathway where you have what I call a megakaryocyte, about a stage 3, stage 4. This is when there are extensions that kind of bud off of this megakaryocyte, and these extensions will break off and enter the bloodstream. So these are literally cell fragments. They're not the entire cell, right? These cell fragments are what we call platelets or thrombocytes, okay? And so these thrombocytes, they remain inactive unless they get activated in the case of an injury where you have to stop blood loss or hemorrhage, okay? All right, so here's a quick summary of all the formed elements that we've discussed so far. So again, this is an overlap with what you also saw in lab as well. Erythrocytes, what you really kind of need to know right now is for lecture is not so much, well, in lab, you're identifying them on a blood smear. For here, I mostly want you all to know what's the main functional role, right? What's the physiological role of these cells? So everything we've covered. So this is just more for your review. You've got erythrocytes, all of your WBC populations, and then finally your platelets right there. So what I want to talk about is what is the role of those platelets, right? How does this play a role in clotting and stopping blood loss? And so we'll talk about physiology. Then we'll talk about pathophysiology, which is like what happens if these platelets don't do their job, right? If you have less platelets or you have an overproduction of platelets and then you have abnormal clot formation. So we'll talk about all of that, okay? So let's talk about normal first, okay? So I'm going to go to the board. We're going to map this out, and I'm missing a whole bunch of markers. What happened? Yeah. Okay. Oh, yeah, that works just fine. Let's try this. So when you look at the lumen of a blood vessel, like I said, this innermost lining is the endothelium, the tunica intima. So this releases two important factors, nitric oxide and prostacyclin. And this allows those platelets to remain inactive. Then we said we've got a layer here, the tunica media, and this is smooth muscle. And the outermost layer here is the adventitia or the externa, which is basically a connective tissue, but a lot of collagen here, reinforcing this. So if you don't have a tear in the blood vessel, all these layers are not compromised. But if you have a tear in the blood vessel, right, then we are damaging the endothelium, we're possibly damaging that layer, and we are probably causing some damage there as well, right? And that's an entire tear in the blood vessel, which allows blood loss, right? Hemorrhaging. So how do we stop this, right? Well, what are the three, oh, we're not tracking. What are the three main steps that would be important for this entire process of forming the clot? Hemostasis is the process of forming this whole blood clot. And we're going to break this down into three main phases and then go into some more details. All right. So the very first step is basically something called a spasm. So this is a vascular spasm. So this is when, if there is blood loss occurring here, right? This layer, which consists of smooth muscle cells, they are going to contract. The muscle cells are going to contract. When the muscle cells contract, what happens to the diameter of this lumen? It basically becomes more narrow, right? So all we're doing is we're restricting the blood loss. Like we're making it harder for that blood to be lost, right? Doesn't stop the blood loss. It just gives you some time. We're buying some time so that other mechanisms, step 2 and step 3, can kick in to actually stem that blood loss. So vascular spasm is where you're seeing those muscle cells. This is related to smooth muscle. This is going to contract, therefore bringing about vasoconstriction. This means constriction of the blood vessel. So you're reducing the diameter of that lumen, narrowing the amount of room for that blood to flow through. So therefore you are kind of slowing down. You're slowing down blood loss, right? So this is vasoconstriction. I'm on a roll today. There you go. The second part is, I'll go ahead and write it, is actually where you're activating those platelets and forming something called a platelet plug. Cover that. And the very last step is what I'm going to call the activation of the coagulation cascade, which I will also further go into some more details. So let's keep talking about this before we continue. So here's vascular spasm. This is all related to the smooth muscle cells responding as they go through contraction. This brings about a reduction in the diameter of that lumen. This is vasoconstriction. So what this is really doing is reducing the amount of blood flowing through that injured blood vessel. Does not actually take care of blood loss completely, but it does slow it down, right? It reduces blood flow, it reduces blood loss until step 2 and step 3 can kick in, all right? So what happens in step 2? So remember, in an uninjured blood vessel, the endothelium released nitric oxide and prostacyclin. Now you have an injury, correct? So what happens is in this area here, these endothelial cells will downregulate, or rather they will lower the expression of that nitric oxide and prostacyclin. This allows platelets arriving in this injured area. It gives it a chance to say, oh, we got a problem here, right? And it starts basically getting activated. What does that mean? Activation means those platelets start getting sticky, okay? When they get sticky, they come together forming what I call an aggregate, right? There's also other things helping this process. This other layer here, collagen fibers are ruptured, right? And that helps to trap all of your activated platelets, which allows more of an aggregate formation, allowing you to form a temporary seal called a platelet plug. Does that make sense? So you got the endothelium downregulating the nitric oxide and the prostacyclin. You got the collagen fibers that are kind of ruptured, like, right? I mean, so they're able to kind of grab on to those activated platelets. Everything becomes a lot more sticky in terms of those platelet cells as part of the activation process, starting to form this aggregate. Then you got this very important factor called VWF, von Willebrand factor, and this helps with that aggregate or the adhesion, right, where you got this complex being formed between those activated platelet cells and those collagen fibers. Does that make sense? This is a very important concept as well. So this is where, again, we're actually forming a temporary seal or a plug. And you have von Willebrand factor that kind of reinforces the platelet aggregate. So as platelets get activated and they start arriving here, let's try a different color. as platelets start getting activated and BWF helps that adhesion, right? So you start having platelets starting to form here and because kind of starts aggregating. Now these platelets, once they're activated, they release chemicals themselves, right? These are like stress signals, and let's talk about that. Some of those chemicals that are released are ADP. This basically allows that stickiness of the aggregate to be facilitated even more so. Then you have other factors like serotonin and thromboxane A2 for the most part. These two are also released by those activated platelets. And all we're doing here is you're allowing more and more platelets to arrive and form a nice seal, a nice plug there. You're increasing aggregate formation. You're also reinforcing that adhesion with those collagen fibers, which helps you form that seal right there where it's needed, where that tear has occurred. Does that make sense to you? If this was a small blood vessel, that platelet plug might be sufficient to stop blood loss, right? I mean, and maybe you don't need anything else. But most of the time, when you're thinking about a larger tear, that is good as a like your first stopgap solution, like a Band-Aid, right? Like that's good. Let's get this process going. But that will trigger the activation of phase 3, which is the whole coagulation cascade. Does that make sense? So let's talk about that next. So do you all understand? When the platelets aggregate, when they become sticky, they start forming an aggregate, they arrive there, they form that plug. That allows chemicals like serotonin, thromboxane, and all of that to be activated. Once that's released, that helps to invite, that helps to draw in other platelets. So this is a positive feedback mechanism. Platelets get activated, you got chemicals. Those chemicals allow more platelets to arrive, there's more chemicals, and so on and so forth, till you form that platelet plug, right? After that, this kicks in, well, almost simultaneously, you already have phase 3 that's been activated. So if you have taken microbiology or any other hematology-based class, you probably heard about the coagulation cascade, and you've probably gone into every little detail for every phase, like every sub step, right? I'm not doing that here. I'm going to give you the broad overview of what phase 3 looks like, right? I'm going to break that down into 3 subphases, but I don't want you to necessarily remember every clotting factor that's involved in this process. Does that make sense? So pay attention to what I'm expecting. You don't have to get bogged down with every little detail. I want you to see the big picture, okay? All right, so let's discuss this. So for the coagulation cascade, this involves a series of different clotting factors because they are promoting or enhancing clotting. These are called procoagulants, right? Which means that you have anticoagulants that would hinder the process, right? So we're going to talk about procoagulants. They all have their own numbering system. So basically, how good are y'all with Roman numerals? Okay, so these all have, they're all numbered by Roman numerals. That's 1 through 13. So you'll see a few of those. I'll explain them as we go. Sometimes you need vitamin K, sometimes, a lot of the times you need calcium, and a lot of the times you need some kind of a charge surface to pull all of this together. That charge surface is right here. These activated platelets, right, presents that charge surface to allow for activation of clotting factors so that now you can reinforce that platelet plug with the help of this coagulation cascade. The idea here is very simple. Is whatever platelet plug you formed here, right, which was a temporary kind of a seal. Again, if you want to reinforce it, this is where you're going to see reinforcement with something called it's a 3-dimensional fibrin mesh. That's what we need to get to, okay? So there's 3 phases here. So I'm going to go ahead and talk about this. Phase 1, 2, and 3. Let's map this out here in just a minute. This is the entire process of hemostasis, starting with vascular spasm, where those muscle cells contract, bring about vasoconstriction, so that slows down blood loss. Platelet plug, that's your phase 2. This is where those platelets that were inactive now have to get activated, forming that aggregate with the collagen fibers, von Willebrand factor, this whole positive feedback mechanism. Once you form that platelet plug, that's going to trigger, for the most part, this last part here, coagulation. This is where, on top of that platelet plug. Now I have to reinforce it with a three-dimensional fibrin mesh. That makes sense. Okay, so that's what I need to talk about here in this part 3. So let's do this. All right, so there's 2 different ways we can activate this. So I'm going to say this. So the first part here is what I call leading to activation of what I call a prothrombin activator. So I'm going to map this out for y'all. There's 2 different ways we can do this. You can use an intrinsic pathway or an extrinsic pathway. So what's the difference? An intrinsic pathway is intrinsic to what's happening inside of that injured blood vessel, which means the clotting factors that are needed for that particular sequence is actually being released from right there. So it's within the blood, it's within the plasma, right? So it's within that injured blood vessel. So it's in-house, intrinsic. But then you can also activate this cascade using an extrinsic or an external pathway, which means these signals, these stress signals, these injury signals are coming from these surrounding tissues here, correct? Not within the blood vessel, but part of the blood vessel in the vicinity of where that injury is occurring. One important factor that kicks off this series or this particular pathway is called tissue factor. Very important. We're going to talk about that. Also goes by Roman numeral 3, but or you can remember it as just tissue factor. So I'm going to explain it to you. This is the entire cascade, and I don't need to know all of those details. So let's get started. Here's my intrinsic pathway, and here's the extrinsic pathway. So intrinsic factor includes activation of several different coagulating factors. All these coagulating factors are within, or clotting factors are within the plasma of the blood. Extrinsic tells me that this signal that triggers this pathway is not from inside of the blood plasma. It is outside from those injured areas, those injured smooth muscle cells, the injured connective tissue. All those are going to release something called tissue factor. Very important. I'm just saying you might see that on an exam. Tissue factor is what's going to start off that extrinsic pathway. Does that make sense? All right, I'm going to zoom in here. I don't need you to memorize it, but I need you to appreciate that there is a lot going on here. It's a multi-step process. It's a sequence, and everything needs to work just right. So I'm going to get to this part here. So I have my intrinsic pathway on the left, extrinsic on the right, correct? So extrinsic is all about activation of tissue factor, and then from there we activate other things. So here, the general scheme looks like this, okay? You don't need to memorize this, but this is what's happening. Let's say in the intrinsic pathway, we're starting with clotting factor that's 12. Do you see it? So all of these clotting factors, just like those platelets, are first inactive. I don't want unnecessary activation of clotting factors, because what would happen then? If you have activated clotting factors, you're going to start the whole clotting process. But if it's an uninjured blood vessel, you don't need that. Does that make sense? So everybody's got to be inactive to start with. Then there's got to be some kind of a trigger that's going to activate all of these factors. So that's what you're seeing here. This is clotting factor 12. And then the fact that you have an injured blood vessel, like the endothelium and the collagen, all of those stress signals are going to activate this first factor. And you see now it converts it to clotting factor 12, but you see that subscript A that tells me it's been activated. Makes sense? Inactive to active. Now this factor then activates factor 11, which then activates factor 9. You see that? So it's a cascade. That's why it's called the coagulation cascade, right? All of these follow in that kind of sequence. Now, there is overlap between the 2 pathways. So in extrinsic pathway, as soon as you activate factor 7, that can then, you can see, feed into your intrinsic pathway and help with the activation of the intrinsic pathway as well. So both are going to work simultaneously for the most part. All very, very rapid, right? In a matter of seconds, we're kind of activating this entire pathway. And there's overlap, meaning there's a lot of redundancy with the system. Redundancy is very good here, okay? We're talking about a hemorrhage. we're talking about blood loss, we're going to activate everything possible to make sure we take care of the problem, right? We've got to stop that blood loss. So that's why you're seeing both those pathways getting activated. They're all basically arriving at the same solution, but we're all going to work together to get to that solution. So there is redundancy. But this is also good because what if you have a deficiency in, say, factor 12, and you, like, you can kind of kick off this pathway? That's fine. There's overlap from the extrinsic pathway, which helps to kind of feed over, and you still have activation. So there's a lot of redundancy with how these clotting factors work, and one can kind of compensate for the other in certain scenarios. Does that make sense? But sometimes there are also deficiencies, and we'll talk about this. Hemophilia is one of them in relation to different clotting factor deficiencies. Does that make sense to y'all? So what I'm doing is, whether you're activating the intrinsic or the extrinsic pathway, the bottom line is we're all converging on this. We need to activate something called prothrombin activator. So both of these are going to converge here. I'm going to create this prothrombin activator. So both of these are leading, correct, to activation of prothrombin activator. I need you to know what's in that, right? How do we get here? So this is activated factor 5, activated factor 10. I need some calcium here, right? And I need that charged phospholipid surface, which is those platelets, right? That's acting as a way to kind of bring all of this together, like a platform. Phospholipid surface. All of this is phase 1, which is activation of that prothrombin activator. Does that make sense to you all? So I need you to know that when you kick off the coagulation cascade, there's 3 phases here. The first phase is how you form, or how do you make this prothrombin activator. It can be done by both intrinsic and extrinsic pathways. I don't need you to know all of this, that as you can see, there's a lot on that flow chart right there. So don't worry about that. For extrinsic, I want you to know what is that extrinsic factor that kicks this off. This is tissue factor, but basically both converge on forming prothrombin activator, which, as you can see, let me get down here, is basically, whoops, right there. I'm going to go zoom out. Don't want to go back. It's factor 10, factor 5, clotting factors, and then you have calcium, the phospholipid surface. All of that basically goes into that prothrombin activator. Okay, does that make sense to y'all? So once I've activated prothrombin activator, then the rest of this is pretty straightforward, right? Phase 2, because this is prothrombin activator, phase 2 would be activation of thrombin. Okay, so let's go to the next slide and we'll map this out again. So we're going with prothrombin. Has to be converted into the active form thrombin. So this is going to catalyze that conversion. That's why this is prothrombin activator. I'm activating it to thrombin. That's phase 2. Right? Once I got that, what is phase 3? This is the last part here. Simple. Is now that activated thrombin is going to actually form that 3-dimensional mesh. So we're going to start with a soluble form, protein called fibrinogen. This was one of those proteins in the plasma, just like albumin and other IgGs and immunoglobulins and all of that. We also have fibrinogen. So what happens here is fibrinogen is like a soluble form. I want to make it an insoluble form so that you can form like a 3-dimensional mesh so that it can sit on top of that platelet plug and reinforce it, right? I got to convert this fibrinogen into basically fibrin. And thrombin does that. And thrombin, this fibrin is basically insoluble. Okay, but we need to reinforce this next. Okay, so once I form this fibrin mesh, I really need to reinforce this. This is very important. This is fibrin stabilizing factor. This is factor 13. So factor 13 has to then get activated to that. So thrombin plays a role there as well. And I'm going to need some calcium for that process as well. So thrombin does two things. It helps with the conversion of fibrinogen to fibrin, but it also helps with activation of factor 13, which is my fibrin stabilizing factor, correct? Now this fibrin stabilizing factor, along with the fibrin, basically forms both of these together, forms a three-dimensional fibrin mesh. That's my bottom line, okay? And that is phase 3 here. You'll see this. Okay, the entire clotting process, hemostasis, involves 3 big steps. The first is vascular spasm, which does not stop blood loss, but it slows it down. Then you have to activate your platelets and form a platelet plug, which is like your temporary seal. May be good enough in a small tear, but most of the times you have to reinforce this platelet plug with a fibrin mesh, a 3-dimensional fibrin mesh. And to get to that fibrin mesh, this is where you're triggering the coagulation cascade, which consists of 3 subphases, like what I have on the board. Okay. So again, if you're looking at your textbook, let's actually look at it. I'll come back to this. This is the entire coagulation cascade, right? Portion in blue is prothrombin activator. The green is basically activating thrombin. And the last part, there's that 3-dimensional mesh. So there's a lot of details here, and I've skipped over some of those details in this phase 1. So what I have on the board is what I'm expecting you to remember on my exam. Again, like I said, if you've taken micro or you've taken another hematology class, you were probably expected to remember every conversion of those clotting factors. All right, so I hope this is clear to you all. I'm going to back up here for a minute. Is that clear to you all so far? Yeah, yes, ma'am. Okay. Oh, if it's a small tear, probably platelet plug is enough. Idea is have you stop blood loss, right? So oftentimes, really, this triggers the coagulation cascade. But yeah, sometimes if it's a very small tear, it may stop with that platelet plug. Okay. But more than likely, you are activating phase 3. Okay. Does that make sense to y'all? Okay, so I'm going to move forward. Yeah, I talked about all of this. So any of these clotting factors, 1 through 13, they are procoagulants. They are promoting, they are helping with the clotting, with the clot formation. Anything that hinders it or stops it or inhibits coagulation, it would be an anticoagulant. Okay, we'll talk about some examples. Here's the entire cascade. This is what a fibrin mesh looks like. All of this straw colored, that's basically plasma kind of reinforced by that fibrin mesh. And you're seeing RBCs kind of trapped there within that fibrin mesh. Of course, there's platelets there as well. There's a lot of different clotting factors, all of that involved in that fibrin mesh. Okay. All right. So once a clot's formed, right, once that reinforcement has occurred, we need to start repairing now. Okay. So yeah, we've stopped blood loss, but we now have to promote healing and repair. So this is when first thing that's going to happen is within the next 30 minutes or so, there's something called clot retraction. So yes, there you got that platelet plug, you got the fibrin mesh, right? But this is going to start pulling inwards. It's going to retract, it's going to pull so that it's very contained to exactly where that tear is, because that's the only place where you need that seal. That's called clot retraction, and everything that's contained in that. So we're talking this activated thrombin, because this is what made that fibrin mesh. All of the different clotting factors that you had activated, all of that is basically pulled into that mesh. Because what happens if thrombin takes off? And if your clotting, your activated clotting factors, right? I mean, if they basically move away, then what happens? Then you upstream or downstream of that blood vessel, you may have undesirable clot formation, and we don't want that. Everything has to be contained. And to promote healing. Why healing? Because we have ruptured the endothelium, you damage the muscle cells, you damage the connective tissue there. All of that needs to be regenerated, right? I mean, we got to heal this. So you have several growth factors. One's called VEGF, vascular endothelial growth factor. This helps with healing those endothelial cells, okay? Then you have something else called PDGF, platelet-derived growth factor. And this is going to help with promotion of injury resolution in terms of those muscle cells that are damaged, as well as here, the connective tissue with the collagen. Okay, so those two growth factors kick in pretty quickly, because once you got the blood loss contained, now we got to heal the blood vessel wall, okay? All right, so once healing has occurred, now you do not have a tear in the blood vessel wall, right? Everything's back to normal, so you don't need the clot anymore. You don't need that fibrin mesh anymore. This then triggers this next process called fibrinolysis. What is lysis? Degradation, breakdown. You're breaking down that fibrin mesh, correct? For this, I need a different plasma protein. This is called plasminogen. Okay, again, it's in an inactive form in the plasma. And then what plasminogen does is it gets converted to an active form called plasmin, and the plasmin basically degrades that fibrin mesh. It breaks it down. Does that make sense? We call it the clot buster. Okay, so plasmin. Plasmin is what's going to break down that fibrin mesh. There's a lot of other factors that help with this conversion. TPA, tissue plasminogen activator. And then thrombin can also kind of play a role with this process as well. Okay, so again, when you need the clot to be formed, when you need the fibrin mesh, we're triggering this entire cascade. Then you're promoting healing, and once healing has occurred, you don't need the clot anymore, so you have to remove that fibrin mesh, and that kind of gets degraded with the help of plasma. Okay. Okay. Very, very important. When you are promoting clot formation, we don't want it to be excessive. We have to make sure that the size and the location of that clot is controlled, right? Don't want an exaggerated clot formation. So the first thing is, as soon as you activate several different clotting factors, when their job is done to form that fibrin mesh, a lot of these clotting factors get diluted out. Basically, they don't remain active for an extended period of time. This will prevent undesirable clot formation. What's really, really important is this thrombin. Once the thrombin gets activated, this is what's going to help with the formation of that fibrin mesh. We can't let that thrombin get away. It has to be contained within the area where you actually have that injury. That's the only place where it's needed to form that fibrin mesh, right? So that has to be very, very controlled. Got to limit the amount of thrombin that's getting activated. What happens if thrombin does get away, right? Because then you can trigger a fibrin mesh in an area where it's not needed, right? So you do have a backup here. This is antithrombin. It helps to inactivate that thrombin that you've just activated in any area where it's not needed, okay? Okay, how do you prevent undesirable clotting? If you have an uninjured blood vessel, there's no need for a clot there, correct? How do you prevent this? It all starts with that endothelium, nitric oxide, prostacyclin. These levels are high in an uninjured blood vessel. I don't need a clot here, which means these levels prevent activation of platelets in the first place. So that's a very important factor that controls undesirable clotting. That makes sense to you? Okay, so let's talk a little bit about, some disorders related to this hemostasis process. Thromboembolic disorders versus bleeding disorders. So thromboembolic is where you have undesirable platelet activation, undesirable formation of that clot, right? In an area where you absolutely don't need it. So this is undesirable clot formation. On the other end of the spectrum, you got a bleeding disorder. You actually have hemorrhage. You want those platelets to be activated. You want to form a clot, but you're not able to form that clot. So this could be a low number of platelets maybe, or it could be some disorders or deficiencies related to the whole clotting cascade. So clotting factors might be a lot of different reasons why you might see a bleeding disorder. Let's start with thromboembolic first and then move on to other categories. Thromboembolic. So basically in an intact blood vessel that's not injured, if you form a clot, This is called a thrombus. So the thrombus that's first formed, okay, it can stop there. It can just be a clot that's formed and it's just stable and it's localized and it's not moving, right? That's a thrombus. But if it finds its feet and starts moving around, and we're talking about moving around in the circulation, so now it's not a thrombus. We call this an embolus, and these emboli can get lodged in smaller blood vessels like those capillaries or anything like that, right? And it can certainly cause obstruction of blood vessels, which means we're not allowing for proper blood flow, which means we're not allowing for RBCs to do their job, which is delivery of oxygen and nutrients that's required for ATP. So this could result in what we call an embolism. If this happening in the lungs, it's a pulmonary embolism. If it gets lodged in brain tissue, right? I mean, we're talking about cerebral embolism. All of this could result in damage of those organs because, again, you are not providing enough oxygen supply. Tissue hypoxia is going to occur, and that could have a lot of negative consequences as well, like a stroke, right? Or like a heart attack, depending on which organs you're talking about. So if you do see that you are prone to undesirable clot formation, you may be placed on anticoagulant drugs, right? I mean, to prevent the formation of those clots, like aspirin, heparin, Coumadin, warfarin, Coumadin, all of those are drugs that are used to prevent undesirable clotting. Bleeding disorders. Okay, so the other end of the spectrum is I do have blood loss. I have to activate those platelets. I want to form that clot, but I'm not able to. That's going to result in a bleeding disorder because you're not able to stop that blood loss. Okay, this could be because you do not have enough platelets, right? Enough circulating platelets. So a deficient number of platelets is what we call thrombocytopenia. Anything less than 50,000 platelets per microliter is kind of diagnostic of this particular condition. Transfusion with concentrated platelets will help with that process. Or it's not about the platelets. It could be something to do with this coagulation cascade. And there's a lot of different things that can go wrong here, as you can see, right? And a lot of the disorders might be related to what's happening here and here, like all of those clotting factors, right? There's 13 of them. There's several things that you need here a little further down as well. So all of those could play a role. This is a broad class of disorders called like hemophilia. Based on where you have a deficiency. You don't quite need to know this, but again, hemophilia A, B, C, all different deficiencies, either in the intrinsic cascade or the extrinsic cascade. This is why there's so much redundancy. So if you have a deficiency in one area, hopefully that should not stop the process, right? I mean, there's something else that can compensate for its loss or deficiency, all right? All right, that wraps up platelets. That wraps up everything we need to talk about in terms of blood. The next set of slides is about blood transfusions, plaqued RBCs, ABO blood types, RH factors, all covered in lab. So the next few slides is exactly what you saw in lab. You all did 2 activities working on these concepts, determining blood type, blood transfusions, determining compatibility between recipient and donor, all handled in lab, not doing it here. Okay, so you have this information, but again, this is all exact overlap with lab slides. Okay, so I'm going to stop sharing. I'll work with you individually on that. Okay, I want to move ahead, but I can certainly work with you individually. Okay, let's see. I need to get to. All right, heart. Let's get started here. Okay, so we're gonna get started with the cardiovascular system. So far we've covered endocrine. Wait, I gotta share slides. Remote users, can you see heart part 1 set of slides? Yes, perfect. So we've covered the endocrine system. We've talked about blood. So we're going to move on to the cardiovascular system. So the first part here is talking about the heart. So this is where it's going to get a little challenging for some of you. Okay, not today. Today is pretty straightforward in terms of the basic anatomy that we need to piece together. But next class, so what's that? Thursday, right? When I meet you, it's on. Okay, I mean, we're gonna have to start talking about different volumes in the atria versus the ventricular volumes, and how that all relates to different pressures, opening, closing of valves, movement of blood through the systemic circuit, the pulmonary circuit, the whole concept of blood pressure regulation controlled by different types of mechanisms. So that goes into a lot of different physiological mechanisms. So I'm going to be very upfront. A lot of students may find these topics a little challenging. Okay, so you may have to listen to that pre-recorded video a few times, especially areas that you're struggling with. You don't have to watch the entire video. Just go to those areas you feel like you need more reinforcement from. Okay, so what I'm going to cover today is an overlap for the most part with what you are doing in lab. This is basically the anatomy. I'm going to map out blood flow and everything, talk about the systemic side and pulmonary side. We'll go more into the mechanics on Thursday. So I need you all to come prepared. Blood part 2 slides, right, is where all that action is going to be. Y'all need to start looking at those slides and come prepared. If you're listening to me for the first time related to those concepts, you may be lost. I need you to come somewhat prepared, some understanding of what we're covering, what's happening here. Because when I start throwing heart rate, cardiac output, how do you control all of that? We need some basics there, okay? All right, so what I'm gonna do here is quickly cover the anatomy, all right? So again, like I said, the first 15 to 20 slides is an overlap with lab. So if you've not heard it yet in lab, you will today. And then you will also follow up and reinforce these concepts next class with Ms. Gosner, where you'll do dissections, also looking at the same anatomy, same chambers, same valves, same blood vessels. You will be mapping out blood flow. You're doing an activity on that on Blackboard with Ms. Gosner. So there's plenty of reinforcement of these topics in lab. So just kind of utilize that time wisely. So I'm going to go ahead and get started here. I'm going to go to the board to map this out. I need some space. So probably this area here, if you need to take a picture or make notes or whatever, but I do need to clean that portion of the board. You good? Only just that portion. Can I go ahead and erase it? So what I'm going to cover here is looking at the heart, the left side and the right side. Again, when you are identifying which is the left and the right side, this is not based on the observer watching or viewing that particular specimen. It is how this is located in relation to where it is in your body, right? So you have to definitely make sure you understand that. I'm going to cover all these concepts. What's the pulmonary circuit? What's the systemic circuit? What are your chambers, upper chambers, lower chambers, all of that. I'm just going to use this kind of schematic to map this out. How many of you have some basic understanding of heart anatomy? Not the physiology, just the anatomy. Okay. All right. When you think about the heart, left side, right side. Okay, this is how it is in your body. Left side, right side. You have these two upper chambers here called the atria, two lower chambers here called the ventricles. So that's the left side. So I'm going to say left atrium, right atrium. These are the ventricles. So again, left ventricle, right ventricle. Okay. These two chambers on the top, these atria are called receiving chambers, right? They're receiving blood from somewhere in the body. This left atrium is going to receive blood from the lungs. The right atrium is going to receive blood from everywhere in the body. Does that make sense? Okay. They're both receiving blood. blood that's received here has to flow downwards into those lower chambers called the ventricles, okay? If I have a solid wall there, that ain't happening, right? Which means I got to talk about valves here. Wait, am I even, yeah, y'all can see it. Okay. We're going to talk about valves here that allow for that movement of blood from the atria on the top to those ventricles below. Okay, so on this left side, you have a valve here called the mitral valve, or it can be called the bicuspid valve. And I also want to say that these are AV valves. All right, what does that mean? Atrioventricular valve. So you're going to see this valve between the atria and the ventricle. Does that make sense? So it's the bicuspid valve on the left side. On the right side, this is the tricuspid valve. So obviously, this is also an AV valve. That makes sense to you, right? Okay, so when these valves are open, that allows blood to flow from the atria down towards the ventricles. Is that right? So then, as blood fills these ventricles, we got to pump blood out of the ventricles into the major blood vessels. So we call these pumping chambers. Atria receive blood, receiving chambers. Ventricles will pump blood out of the heart, right? Wherever it needs to go, I'll map it out. So these are your pumping chambers. Does that make sense to you? So let's start talking blood supply, right? Systemically speaking, meaning everywhere in the body. General rule of thumb, there are exceptions. So I'm talking about the general rule of thumb, right? 99% of the time, if you're looking at systemic circulation, if you see the word artery, this is a blood vessel that carries oxygen-rich blood. Okay, and you're carrying oxygen-rich blood away from the heart. I'm going with red. This is where all of your designation of oxygenation in terms of blood in all of the schematics in your textbook, red means oxygen-rich blood. Does that make sense? Which means blue on the other side, this is a vein. This would be a blood vessel that carries oxygen poor blood. And we're always returning this blood back to the heart, right? So we are oxygen towards heart. Does that make sense to you all? So I have oxygen-rich blood being carried by some kind of an artery to your tissues, your cells, where I'm going to utilize that oxygen. And then all the CO2 that's building up in your tissues will then be returned through a vein, okay? So this could be, you can say oxygen poor blood, or you can say CO2 rich, same thing, okay? All right, does that make sense to you all? This is the general designation of an artery and a vein, all right? But in the lungs, when you're thinking about blood flow into and out of the lungs, this is the pulmonary circulation. These two terms are reversed. That is my exception to rule. Does that make sense? Got to remember this because this is what you see throughout the body, right? In lab, when you'll start working on blood vessels, you'll cover about 50 something different types of arteries, different types of veins here. When you're identifying all of this, you need to just know what's an artery. Okay, oxygen-rich blood away from the heart. What's a vein? All right, some kind of a blood vessel is carrying oxygen-poor blood back to the heart, right? But if you're thinking about blood flowing in and out of the lungs, reverse it. There's also another place where we reverse this, fetal circulation. So prenatally, during the development of the embryo and the fetus, right? That's where those designations get swapped again. I won't cover that right now. I mean, we'll talk about that towards the end of the semester when we get to pregnancy and fetal development. But right now, I do have to show you how this is reversed with respect to the lungs. So let's get started. So up here, we got lungs. So the left and the right lungs, correct? So you are breathing in oxygen, inhalation. All right. Inspiration, you're drawing in oxygen into those alveoli. And there's blood vessels serving those alveoli. Guess what? Inside those blood vessels, you got RBCs. Remember what we talked about last class? RBCs are modified. 97% or so of the interior of an RBC is packed with a protein called, what now? Nope, not albumin. Try again. Hemoglobin. Remember this? Hemoglobin? Right. Okay. So as you breathe oxygen into the lungs, what happens? The oxygen gets coupled to the hemoglobin. We talked about oxygen loading happening here in the lungs. So we got hemoglobin coupled to the oxygen. This is oxyhemoglobin, correct? So all of this oxygenated blood, right? Oxygen-rich blood, that's why red, okay, is returned from you have to move it out of the lungs, and we're moving it there into that left atrium. Does that make sense to you? There's two vessels from the left lung and two vessels from the right lung. So that's a total of 4 pulmonary vessels carrying oxygen-rich blood into that left atrium. Oxygen-rich blood, typically we call it an artery, correct? But remember, we're reversing it here for the lungs. So this is oxygen-rich blood from the lungs, but we're not going to say artery here. We're going to say pulmonary vein. Does that make sense to you? You have to change that designation. So I'm going to go with 2 left pulmonary veins and 2 right pulmonary veins, right? So you got 4 pulmonary veins carrying oxygen-rich blood, red, into that left atrium. Does that make sense to you all? Okay. As blood fills in that left atrium, it's going to exert pressure. Pressure inside this left atrium is going to increase. Therefore, this valve opens. So if I have an open valve, now that blood from the left atrium is going to go through that bicuspid valve, and all of that blood is going to start to fill the left ventricle. Does that make sense to you? When the ventricle goes into contraction, because the wall of this ventricle has cardiac muscle, as it starts contracting, blood's going to be pumped out of that left ventricle. Is that right? Now I'm going to move it out of the left ventricle. What's the biggest artery in your body? Aorta. Heard it. Aorta. All right. From here, you have the aorta. So I'm going to go with, there's a valve here that opens the aorta, and I'm going to still continue with red. I'm going to go this way. That's the aorta. The aorta has many, many branches, which I won't do here in lecture, but you all will cover this for lab. You'll spend an entire lab talking about arteries and another lab identifying all the major veins. So we will talk about all of that in lab, but right now I'm just saying oxygen-rich blood from the left ventricle gets pumped out into the aorta and all of its different branches, correct? So you're going to distribute all of that oxygen-rich blood to the head and the neck region, to the upper limbs, the thorax, the abdomen, the pelvic region, the lower limbs, everywhere in the body. Make sense? So we're distributing it to all the tissues and cells. Does that make sense to y'all? All right, before that, this valve needs to open to allow blood from the left ventricle to enter into the aorta. This valve is called the aortic. This is not an A-B valve. This is called a semilunar valve. Does that make sense? So as I distribute oxygen-rich blood, so just remember this is hemoglobin bound to the oxygen, right? Oxyhemoglobin, that's how I'm transporting it here. When I get here, so really all of these are like arteries. Right? Arteries are carrying oxygen-rich blood away from the heart. The aorta is an artery. And then you got to talk about different classifications of arteries, different names based on where they're leading towards. All of these arteries are carrying oxygen-rich blood to those tissues. Now what happens? This is where inside the tissues, we're talking about exchange vessels here. These are capillaries. Capillaries are, you remember we had a description of the vessel wall, a blood vessel wall. You had 3 layers, a capillary is an exchange vessel. You don't have 3 layers, you just have that innermost layer, because this is where exchange of gases and nutrients needs to occur. All the oxygen from the blood will enter the cells, right? Which means this is where I'm going to unload the oxygen from the hemoglobin. I'll uncouple it, I'll break that bond. Now the oxygen is utilized inside the cells. What is happening here? Cellular respiration. Okay. This is where in the presence of different substrates like say glucose, I'm going to actually utilize that oxygen to form, yeah, you're going to form some CO2, you're going to form water, but really you're forming ATP. That's the most important thing, right? So I'm utilizing the oxygen inside those cells and tissues to form ATP to drive cellular needs. Is that right? But in the process, what am I doing? I'm also building up CO2. CO2 is an acid, right? So as CO2 builds up inside these cells, because it's an acid, we're going to lower the pH, resulting in acidosis. This is metabolic acidosis. This is a problem, correct? I don't want the CO2 to build up inside the cells. So what can I do? I can take that CO2, move it out of the cells, put it back into the blood to return it to the heart, okay? Except I can't load the CO2 on the arterial side. This is all unidirectional flow of blood. You see that? Blood's coming in into the left atrium, down that valve to the left ventricle, out through the aorta to reach the tissues. Can't go back that way. Unidirectional. Does that make sense? So as I load the CO2 from the cells, as they're building up here, how do I load it? Not on the arterial side. Go with blue now. This is oxygen poor blood, out the cells, out the tissue end of things. This is where I start talking about veins, right? A vein is going to carry oxygen poor blood or CO2 rich blood back to the heart, okay? So I'm going to talk about returning all of this CO2 rich blood through veins, okay? Small veins that all then become your three big largest veins. I'm going to go with all the venous blood returning from the abdominal region downwards. All of that is returned through the inferior vena cava. All the venous blood from the head, neck, upper extremities, all of that is not IVC, inferior vena cava. This is superior vena cava. Those are your two important vena cava. Superior for all the upper extremities, inferior from basically thorax, abdomen downwards, right? But then I also have to return venous blood from just the heart. I mean, the heart also has to function, right? I mean, all that cardiac muscle, it's working 24/7 from the time you're born to the time you're down. Never takes a break. That cardiac muscle is also generating ATP every single minute, but it's also generating CO2. So I've got to return venous blood from the heart. This is part of what I call the coronary circulation. It's only specific to the heart. It makes sense? So a whole bunch of cardiac veins will come together, right? Forming a large vessel called the coronary sinus. Okay, so there's three big veins, superior inferior vena cava, and then the cardiac output from, like the venous output from just the heart, the coronary sinus. These three will open into that right atrium. Does that make sense? Okay, now what happens? As you fill the right atrium, pressure here will increase. So we open this valve. This is the tricuspid valve. So then blood's going to flow downwards into the right ventricle. Is that right? Okay. As you fill the right ventricle, this is what's going to open up my next vessel here. There's another valve here. I'll talk about that. But this is called the pulmonary trunk. So I'm going to lead out. This is the pulmonary trunk, which then splits into two major vessels. One goes into the left lung, the other goes into the right lung, correct? So this is carrying blue. This is oxygen poor blood, correct? So typically I would have said this is a vein, correct? Except this is blood flowing into the lungs. So for the pulmonary circulation, you have to change the designation. I'm not calling this a vein. I'm going to have to call it a pulmonary artery. So left pulmonary artery and right pulmonary artery. I'm carrying oxygen poor blood or CO2 rich blood into the lungs, where as it fills the alveolar spaces, I'm going to exhale that CO2, expiration. You see that? Okay. This is all unidirectional. I forgot to mention this. This valve here that opens out into the pulmonary trunk, obviously just like that valve, this is called the pulmonary semi-lunar valve. Okay, all unidirectional flow of blood, meaning blood's always going to flow in one direction. Cannot go backwards. That's why you got valves that helps to prevent a lot of this backflow if everything was working right within the heart. We'll also talk about valves that you will see on the venous side as well. Okay. So again, I want to point out a few things before I let you all go. When you're looking at the left side of the heart, this is the left atrium is receiving oxygen-rich blood from the lungs. pumping it down to the ventricle, left ventricle, and then from there it's leading out to the aorta to be distributed everywhere in the body, correct? So the left ventricle is distributing all of that oxygen-rich blood everywhere in the body. So we call this left side of the heart that's dealing with only red, oxygen-rich blood, and you're distributing that blood throughout the body. We call this the systemic circuit. Okay. The right side of the heart is receiving venous blood from everywhere in the body, pumping it in the right ventricle and then out the pulmonary trunk. And where am I taking it? Only to the lungs, correct? So the right side is only dealing with oxygen poor blood, and it's only pumping it to the lungs. So we call this the pulmonary circuit. Does that make sense to you? Okay. Let me go here. What I have mapped out on the board is kind of what you're seeing here. Again, this is all unidirectional. This is called the circulatory system because the movement of blood or the blood flow is in a circulatory pattern, meaning you can start anywhere, right, within the heart or wherever. If you start here, you can map out the blood flow and you come back to that point. Wherever you start, you're going to end back there because you can go entire full loop, right? Full circuit to come back. That's why it's a closed circuit. It's called a circulatory system. Later on, when we talk about the lymphatic system and talk about lymph flow through lymphatic vessels, you're going to see that that's a little bit more open-ended. You don't say lymphatic circulation. You say blood circulation, though. Does that make sense? Yes. All right. Based on anatomy, all of this you will cover in lab. This is all mostly for identification on a lab exam. Where it is housed in the thoracic cavity. There's always coverings that protect the heart. Again, Ms. Gosner will cover it. If you were in the Monday, Wednesday lab, I covered it. So this was your pericardium, the different layers. All of this is lab relevant. Okay, so this is again for y'all to look at. Different chambers of the heart. We talked about this. There's a septum here between the two atria called the interatrial septum. Septum here between the two ventricles, interventricular septum. Okay. What I have on the board is basically what you see here. Okay, I will come back next class. Y'all need to be paying attention in lab. Okay, you need to figure out how this is going to flow. By the time we're done with this discussion in probably about the next 2 weeks and for the remainder of the semester, you should be able to draw that out in your sleep. I mean, really, I'm not joking. I mean, y'all should know this is the basics. If you're going to be in a clinic, y'all don't have to sit down and think, wait, what vessel comes where, what? No. It should just come out of your mouth. Like you shouldn't even have to think about it. You should get that down packed. Does that make sense? Y'all need to work through this. This is not difficult to draw. You don't have to be an artist. I'm not an artist, but I do just fine, right? Put this on a piece of paper, map it out, practice with it. What are my atria? Where are my ventricles? What are my valves? What are my blood vessels? Do red, do blue, which is oxygen rich, which is oxygen poor. How is blood flowing? You actually have an activity in lab where you will be tested on these, or you'll be practicing, right, for all of this. So you'll get a lot of practice as well. When you do dissections, do the same thing. Look for those chambers, look for the valves, all the major blood vessels, map it out. We start here, where's it going to flow next? And all of that, right? I mean, like, do that exploration. That's very important. I will come back and review this next class before I have to start throwing in physiology concepts. But again, the internal view of what you see here is what I kind of have mapped out on the board, okay? Again, a lot of anatomy. I'm going to let Ms. Gosnell cover all of this. I know I covered this yesterday. I will come back and talk about a few more concepts. I'm going to stop there. Do you all understand the pulmonary circuit and the systemic circuit? I will review this in next class. Okay, I'll map it out again. You're going to help me. Okay, we're going to map it out, make sure we've got that right, and then we're going to move into some more of the physiology, which we need to start covering. Okay, please come prepared. This pretty intense concepts that I need to cover with you on Thursday. And I'm not joking. It's pretty intense. So please come prepared. Okay. All right. All right, I'm going to say bye to you all, remote users. If you all have no questions for me, I don't see anything in the chat. Okay, all right, bye. Have a wonderful rest of your day. See you Thursday, okay? Bye.